the nursing voice in these discussions around what to prescribe for X, Y, or Z condition carries a lot more weight, plays a bigger role, maybe than the research in safe prescribing has given it credit for. Your words matter. Your suggestion can actually sort of kick off, are we going to go down this path or are we going to go down that path? And that can be pretty consequential, not to put a whole lot of pressure out there, but you play an important role. Don't feel like your words don't have value. They really matter.
Hey everyone, welcome to the Nursing Insights podcast. My name is Stephanie and I'm a registered nurse practicing in the state of New Jersey. Getting right to it, the state of healthcare right now is tough, to say the least. Let's just say that the nursing shortage does not spark joy. We can sit in that and stew in it for a while, but we can't live in it forever. Things are changing. So join me as your host as I partner with the New Jersey Collaborating Center for Nursing to hear from nurses across the state about their experiences, trials, and triumphs in the nursing profession. Today, we're diving into a game-changing approach to medication safety in older adults, the Geriatric Prescribing Context. We have three wonderful guests who are specialists in this, and I'm so excited to introduce to you, first, Dr. Katie Drago, who's the original researcher and geriatrician who developed the Geriatric Prescribing Context. Thank you for joining us, Dr. Drago.
Thanks, Stephanie. It's a pleasure to be here.
We also have Jean Stoerger, PharmD and clinical geriatric pharmacist. Thank you for joining us, Jean.
Thank you, Stephanie. It's a pleasure to be here.
And finally, we have Jo Phillips, DNP and Geriatric Program Director. Thanks for joining us, Jo.
Thanks so much, Stephanie.
We're super excited to dive into this conversation. We would love to hear a little bit, if you don't mind starting us off, Dr. Drago, with what is the GPC and why does it matter?
Well, that's a wonderful question, and it's such a delight to have the time and the space to really dive into this topic with Jo and Jean, who are just forces of nature. So for all of the listeners who I imagine play different roles in healthcare, it's probably not lost on any of us that medications can be a real troublesome spot in healthcare especially for older adults, for those that are physically frail, or for those who take an ungodly amount of medication every day. And in the inpatient space, where we are making lots of changes and there's lots of things happening from moment to moment and day to day, medication-related adverse drug events, particularly related to dosing, that, older adults just need something a little different, happen all the time. Every day, every shift, all the time. We know that there are a lot of medications that really we would prefer not to use at all, but there's arguably a bigger pool of medications that may be appropriate for an older adult, but at a different dose or a different frequency than we're used to seeing, or as a prescriber used to ordering for younger adults. Yet the electronic medical records and computerized order entry that we use were never set up to help support that differential, that sort of change in dosing need over the course of the lifespan, unless you're a child. Once you move past the age of 18, the EHR treats all adults as just one big bucket of adults. And what we know from clinical practice is that is not the case.
So could you bring it to life for us a little bit? What does that look like in practice?
That's a great question. So what we did was recognize that there is this need. And of course, all great stories start with a great case. In our case, the situation of Pastor Bill, his name has been changed, but the details of his situation are really kept the same. He was 90 years old. He had slipped on his front stoop in the middle of an ice storm that we have here in the Pacific Northwest, and fell and hit his head, and he had a small, almost inconsequential subdural hematoma that was found during routine trauma scanning when he came to our ER. Was admitted to an intensive care unit for closer monitoring, had a series of float pool nurses that were caring for him. He was in the medical intensive care unit instead of the trauma surgical intensive care unit because of bed flow and capacity challenges. So kind of a comedy of errors was starting to occur. He developed a very mild case of delirium with a bit of restlessness, no significant behaviors. He just wanted to get up and go see people and do things. Very pleasant in the middle of the night. A float pool nurse who did not usually work with this population was caring for him, kind of became overwhelmed, paged the overnight surgical intern who was wearing the belt of pagers, covering all of the surgical services, something like hundreds of patients across the different surgical specialties. And between the two of them, reviewed the case and said, okay, well, I know he's delirious, and I know in an ICU, delirium usually crosswalks over to haloperidol. So this intern earnestly went to our EHR, which was Epic, typed in haloperidol. The order box came up, and the buttons of the doses that were suggested were listed as 1 milligram, 2 milligrams, 5, and 10. And thinking that, well, this is kind of mild to moderate. I just want a moderate dose. So he clicked the dose in the middle, which to him was 5 milligrams. So ordered a dose of 5 milligrams of IV Haldol. That was given. Ended up getting a call back, ordering another 5 milligram dose of IV Haldol a couple hours later. And then before the end of night shift, ended up adding on 25 milligrams of quetiapine. I came in the next morning. I had met this gentleman a couple days earlier for a falls risk assessment. And I came in the next morning and looked over his MAR and his record, and it turned out he had gotten 10 milligrams of IV Haldol and 25 of quetiapine. Best practices for older adults when it comes to haloperidol specifically, but all antipsychotics. For Haldol, the recommended starting dose is 10 times less for an older adult. It is 0.5 to 1 milligram. And so he ended up getting 10 times the recommended starting dose of haloperidol for an antipsychotic naive person with no primary psychotic disorder. I went to see him because I was worried about him, and it turns out he had what looked to be, and through workup, an acute dyskinetic reaction in his diaphragm. Remember, the diaphragm is skeletal muscle. So, and you can get an extrapyramidal or dyskinetic reaction of the diaphragm where it effectively twitches instead of has nice coordinated, smooth contraction and relaxation to control the breathing, and he ended up dying of respiratory failure. That we believe, after doing, of course, the usual workup, was related to an acute dyskinetic reaction due to the load of haloperidol that he received. So his case went through interdisciplinary root cause analysis and case review with the trauma surgical service, our geriatrics team. And we pulled out a couple of different threads that contributed to this man's passing. One of them, of course, was, were antipsychotics necessary, which could be a whole other podcast. So please invite me back to talk about that. But the second layer question to that was, what role did the dose and the EHR play in the doses that he ultimately did receive? We talked to the intern, to the nurse that we're on, again, not through a blame and shame approach, but through kind of wanting to understand what had happened. And we got the story from the overnight intern saying the buttons were there. I picked the one in the middle because I assumed I wanted kind of a medium dose. And I assumed that the EHR knew what I needed. And so, which turns out we know was not the case. That's just not how EHRs are set up when it comes to computerized ordering. So the team of us said, well, this feels like an easy fix, right? We can go to our physician informaticist and just ask, we have this case. We think the buttons that were suggested was an issue. Can we change it? And so we did that, went to our inpatient physician informaticist, who was wonderful and very supportive of the idea. And he said, couple of thoughts. This functionality to recognize the age of the patient and know to offer some different dose and frequency defaults already exists. This already exists for children. Because for all sorts of medications for children, and I'm sure Jean can talk more about this, they often need weight-based dosing. The dose defaults are often different when you've got a tiny, 20, 30, 40-pound child compared to an adult, even though we use the same medications. So the EHRs are quite capable of doing this. And he said, it's not just haloperidol that could use this kind of treatment. Why don't you go through and all good deed, no good deed goes unpunished. So he said, why don't you go through and look at all of the commonly used medications and come up with what the dose defaults should be for older adults. And that is the GPC. It is a background logic in EPIC that recognizes when a prescriber is in the chart of a patient who is over the age of 65. We started with 75, just to be a bit more conservative, but have since moved on to include the entire population of adults over the age of 65, and recognizes when the prescriber goes in to order one of 51 different medications across 8 different drug classes, and it is the common medications: vasoactive drugs, sleepers, antipsychotics, opioids, the heavy hitters in inpatient spaces. If you order one of those medications, it automatically knows to offer up to you different dose defaults that are more age-friendly and age-appropriate. So now what we've done is we've actually brought to life an assumption that a lot of prescribers and pharmacists and clinicians had about the EHR, that it could nudge them and suggest to them maybe a better way or the right way to do things. And now it actually does.
Dr. Drago, that is an amazing story. I know you were saying that it's no good deed goes unpunished, and you had a lot that came out of that, but I can't even fathom how many people you've helped with that work. I mean, when you were sharing the story with the dosages, the majority of my clinical practice has been evening shift med-surg. So when you were sharing the dosages, I just got chills, and I'm like, oh no, this story is not going to end the way we hope it is, I'm sure. But the work that you and your team have done coming out of that is just something that's really going to revolutionize care for so many people. And I am so thankful on behalf of, I'm sure, the community of people who are going to benefit for that effort that you put in. And I think the complexity behind having to do all of that, going in and speaking to, the informaticists that you were sharing with, having the collection of colleagues who are on board and doing the review and the research, that is so much more complex than I think anybody kind of recognizes from an initial viewpoint. Would you be able to share with us a little bit more about some of those challenges that you would have experienced in the process?
Yeah, I make it sound so easy. But it really this whole process took about a year from sort of start to finish, and start being the case review, not necessarily Pastor Bill's death, because we didn't really know what we didn't know. So it was a lot of reading, published literature that was out there, a lot of reaching out to colleagues that also used EPIC at different institutions, both in the Portland metro area and then nationwide. Have you had this kind of problem? Do you have a solution for this? Does something already exist in EPIC that maybe we could pull down from the EPIC Community Library, which is a very, very cool resource for those that are EPIC affiliated institutions, where you can go and actually see what order sets do other institutions use, what modules or what code are they using for a whole host of different issues. So, but I, as a regular Joe provider, didn't have access to that. So getting access to the right pharmacy informaticists that have access to that part of the community library to see, can you help us with this? Of course, capturing the attention and getting on the priority list for our informatics colleagues to investigate and explore this work is always a challenge. There never seems to be enough informaticist time to do all the wonderful things that I know all of us want to do. So it was a lot of talking to people, and it was a lot of making the case for why this is important, sharing Pastor Bill's story, sharing the experience of night shift med-surg, where this happens all the time, constantly bringing up those issues to different venues and different people in different positions to say, this needs to get fixed. This is happening, whether we recognize it or not. And we really want to do something about this. We feel like this is something an area where we can make an impact. And so it really did take a year of garnering support, getting people on board, exploring what existed in the landscape, realizing that there wasn't a great solution that was already out there that we could capitalize on, and then saying, well, guess we're going to build it ourselves. And then the process of myself, a geriatrics trained PA who is one of my partners on our inpatient geriatrics program, and then the chief of our medicine service line pharmacists, just sitting together over a series of meetings with our lunch and coffee and LexiComp and micromedics and our own clinical experiences, difficult cases that maybe we had that week regarding different medications, and then just poring over this list in a really iterative fashion, using the resources and expertise we had, vetting that list with other providers, other supportive colleagues of ours. Are there medications that maybe you've had a bad experience with or patients have had a bad experience with that should be on that list? Are there meds on this list that shouldn't be on this list? So the whole process, start to finish, took about a year, but it was all worth it. I think the process of discussion, pause, coming back, vetting with other people, really sitting with this idea and letting it grow almost in an organic fashion, I think was one of the reasons that it turned out to be so successful in the end. Great things do take time. For those who are gardeners, I think you know that. I'm a knitter myself. Great things take time. And so this is just another example, I think, of how great things take time.
And it truly does sound like a great, great thing. Another thing that you had mentioned in your story of the development is how in the previous iteration, that intern expected that the technology would just push him in the right direction. And we know that as technology is such a powerful tool in our practice, it is not always that smart. And you had to do a lot to get it to be that way. Now that it is, set up to be able to help act as a service, as a guidance, or a guideline to our providers. Would you be able to tell us a little bit about how the GPC is now different for the practitioners in use? What does that look like?
Yeah, so it actually looks invisible to the end user. And that's one of the magic pieces about this. I don't know about the listeners out there. I, as a crusty old physician, really get crusty and prickly when my workflow, when I'm writing orders and I've already decided what I'm going to do, gets interrupted by a big red angry BPA or an alert, a hard stop saying you've already gone through the cognitive process of deciding you were going to order this medication at this dose, but yet we need you to do a little bit more to justify why you're doing this. That is a one-way street to making Dr. Drago very prickly. And I know this is true of a lot of my colleagues too. And I bet it's true of a lot of people listening to this podcast because it just doesn't fit with our cognitive workflow, the very granular steps that we've already gone through to decide, yes, I want to order this medication at this dose. I understand it's risky, but I have a plan to balance those risks, right? That hard stop at the end of that process is just another annoyance. So we were very, very clear from the get-go. We do not want to add another hard stop or a big red angry alert saying, okay, now justify to us, right? Nameless, faceless epic, why you're doing what you're doing. So instead, we were really drawn to this magic of the pediatric prescribing context because it is invisible. I'm fond of calling it just a nudge in the right direction, which it turns out is what most prescribers are looking for. They're not looking for a big angry red alert or being asked to prove their work, the cognitive work. They're just looking for a little nudge in the right direction. So unless a prescriber had two charts open at the exact same time on two different screens, one for a 40-year-old, one for an 85-year-old, and they were both looking at the same medication, say oxycodone, you would not notice the difference. Because for that 40-year-old, the defaults at OHSU still are 5, 15, and 30, which seems kind of odd. But the defaults that are available for that 85-year-old, 2.5 to 5, the range is already in the box. For those who use Epic, the box that you don't even have to click a button to pick a dose, or you can pick just straight 2.5 or 5 milligrams. There's no angry red. There's no hard stops. It is just a little like bumpers on a bowling alley to kind of nudge you back in the right direction.
That's amazing. And it really does allow our practitioners to do what they do best, which is not fight with technology. This is not Skynet.
Yes.
This is being able to do the practice and their care of their patients without having to, go through all of, like you were saying, the red flags and the frustration, but still being able to deliver the best care possible. And I am certain that you have probably had some amazing outcomes, some interesting research or findings coming out of the work you've been doing. Is there anything from that line you'd be able to share with us?
Absolutely. So I believe there are going to be links to our published work on the GPC with this podcast. So for anyone who is a real data nerd, please, in your free time, which I know you have lots of, take some time to read our published work. We did, in the beginning, a 1-year pre and post implementation study looking at the rate of active orders placed we looked at the top 10 most commonly used medications of the 51 that were modified just for big enough Ns, right? Big enough total number of orders. And we just wanted to see how many of those orders pre and post were being written for the age appropriate GPC defaults. And what we saw in this initial investigation was that there was anywhere from 10 to 30% increase in the use of the age-appropriate GPC defaults in orders for 9 out of 10 of these top 10 most commonly used medication. The only exception was hydralazine. And it turns out at the exact same time, in parallel, there was an institution-wide effort to decrease the overall usage of PRN hydralazine based on some good data that had come out of the VA at the time, that it really causes more problems than it solves. And so we saw the orders for lower doses of hydralazine go down in the post period, probably because the overall number of hydralazine orders went down, and they ended up being for those kind of worst of the worst, quote unquote, cases. So we had a really satisfying explanation for why that was, and felt like had that other work not been happening at the same time, we would have seen a perfect score across the board, that we would have seen statistically significant increases in uses of the orders, the age-appropriate defaults. We then looked at 4 years after implementation just to see, does the effect stay? Does it wane over time? And it turns out, long story short, the effect is sustained over time, which is a really important thing to take note of, because other safe prescribing interventions that have really focused on things like staff education and other, what I'm going to call more ethereal interventions, wane over time. The average is that the effect wanes after about 6 months. And that's because we all have our bad habits that we fall back on. And staff turnover is a huge, huge deal. So with educational interventions, you really have to constantly be reiterating that same information to capture folks coming in, folks transferring in from other units, other institutions, or just to match the constant ebb and flow of staff. This is totally different. This is a systems-based hardwired intervention. So the effect does not wane. And we're an academic institution. There were constantly new residents, new interns, new faculty, new APPs coming in, and the effect did not wane over time. We also looked at provider and pharmacist satisfaction and ordering experience. And it turns out the funniest result here is that 75% of those that were surveyed had no idea that the GPC even existed. So call me simple-minded, but I would take that as a really good proxy measure for no alert fatigue, because you can't be fatigued by something you didn't know existed. And the vast majority said that, there has been no adverse effect on my workflow. Even the pharmacists as well were like, yep, this is great. There's either been no effect on my workflow, or as prescribers and pharmacists, they said, yeah, I did start to notice that the defaults were different. And that actually was a positive effect on my prescribing habits, because I recognized oh, okay, there's something here, right? So there's a little nugget here that I can pick up on. And then the brass ring, after all of that, just understanding how it was working, was we looked at dose-related adverse drug events during actual admission. So we did another 1-year pre and post implementation study, looking again at those top 10 most commonly used medications. And they're the meds you wonder about. There's opioids, a couple of antipsychotics, trazodone, Benadryl, right? It's the huge. And we saw a 50% relative risk reduction in actual dose-related adverse drug events experienced during hospitalization. This was huge. We saw a trend towards overall decreased severity of adverse drug reactions as well during that time, but numbers were so low it was not statistically significant, but the trend is pretty notable. So for anyone who's really interested, go look at the tables in the, I believe it was published in 2024. Finally published in JAGS, the Journal of the American Geriatric Society in 2024. There's a great table showing the severity rating and the actual dose-related ADEs per patient days that you can see there is a greater than 50% reduction and an overall trend towards reduced severity of ADEs. So long story short, this works. This is protecting patients. And Epic actually took note of this and said, wow, this is awesome. So for all of you new Epic users after November of 2023, you have the GPC. It is part of what they call the Foundations package. So the off-the-rack version of Epic for any new institutions that bought into Epic after November of 23. If you were an OG user from before November of 23, it is available in the community library for your pharmacy informaticist to sort of pull down and with instructions to build locally.
It's wonderful to hear that all of your hard work is continuing to go out into different geographies so that so many more people can benefit from the hard work you put in, and so many people can have that experience, both practitioners and patients, of having that best care practice. I'd love to hear now about how, it's now built in for many of the Epic users, but it wasn't for everybody, as you had shared, and the GPC had to be introduced and piloted in some cases. I believe we have one of our guests here on is a geriatric program coordinator. I believe that's you, Mary Jo. If you don't mind sharing with us a little bit about how was the GPC introduced and piloted in your facility?
Yeah. So I think what happened was that even though Katie was in the Midwest, we here on the East Coast were having some of the very similar issues. We recognized that there was a gap in safe prescribing, and our providers were simply just unaware of what medication were on the Beers list. I'm not sure if Katie referred to it, but I'm going to try to hone in on it for a second, is that there's a list of potentially dangerous medications for our older adults that then goes over, hey, this is why it's dangerous. It's going to go through another iteration. It has gone through several. There's going to be a new iteration that's going to actually give you a column that says, guess what? Here's some alternatives. Many, Jean, I'm sure will share, will be non-pharmacological. But truly, that was our starting point. And just calling another fact to light for our listeners too is less than 1% of the healthcare workforce is formally trained in geriatrics or gerontology. So what we are trying to do, right, as individuals that have really taken this on and gotten better education, is help more than 99% of the healthcare workforce understand all these different nuances. And I'm sure you've heard the graying of America, the silver tsunami, the age wave, right? Our number of older adults is going to outnumber adolescents for the first time in our country's history. So there is the demand. There's the demand from all of these healthcare systems to say we have to do something to help bridge the safety gap for this population because they're here and they're also going to be growing. Jean and I first befriended each other. She is the geriatric pharmacist that works at my organization with me. And we started talking just about different medications and how passionate we were. And Jean and I said, we know exactly what we're going to do. We are going to go to our clinical decision support team and we are going to show them this list of medications, and they are going to agree that there has to be hard stops. We can't let anybody do this, and we have to make it so much safer. So we proudly walked into that meeting and we were denied. So organizational best practices, BPAs, those interruptions in workflow are just not something that our end users want, whether that be providers, nurses, it honestly doesn't matter. So they said, we agree with how important this is, but we think what you need to do is a nice passive sidebar summary. So Jean and I said, we will do that, with bells on. So we went for every specialty area, nurses, pharmacists, and physicians. We actually wrote those guidelines according to their scope of practice. So for the nurse, we would say, suggest to the physician. For the physicians, we would say, order. Jean and I let that go on for a little while. And then after about a year, we looked at the data again. And I know, no surprise to anyone, we actually did not see any improvement in practice. So what happened was then I happened to sit next to Katie at a conference. I think it's important at this point too, just to pause for a moment and explain why Katie and I were there together. Just really calling out the IHI and this age-friendly health system idea, the 4 M's, what matters, medication, mentation, and mobility. And what happened was IHI actually, we are going to provide links to this as well, allows free of charge hospitals and organizations to join action communities and to say, hey, we want to be part of this. And we're hearing it's just as easy as these 4 different M's. And now we're also hearing that there might even be a really simple solution in the realm of the M of medication. But we linked this to a bigger goal that our organization had, a real strategic initiative to enter into safe geriatric care in many spaces. So in addition to the IHI age-friendly, you have the Geriatric Surgical Verification Program. We have geriatric emergency department accreditations that you can receive. And what happened was Jean and I got a call and they said, what are we doing for all these medications? And we proudly says, don't worry, we have amazing passive sidebar summaries. And then they said, great, how is that improving care? And we said, well, about that. Which is really what prompted myself and Jean to start talking with the folks that were going with the geriatric surgical verification, talk with the folks at our organization that were really invested in the Geri ED, and to say, we have to look at the literature. We want to see what the best thing is. And I also said, well, I actually sat next to this doctor at a conference. So that's how all that got started at our organization.
That's amazing. So when you did get a chance to start to integrate the GPC in, how did that process? It went from, I sat next to this doctor at a conference, and then suddenly it became, our health system has this new nudge tool to help our providers. How did that transition go?
So I think one of the biggest things was creating an interdisciplinary team. We needed, very similar to some of those grassroots efforts that Katie and her team had, but we really needed nursing to come together with pharmacists. I have we work with Dr. Perulakar, a very strong geriatrician at my organization. And we all came together and said, are we all on the same page? Is this something that we want to do? Because at that time, we were an OG. So we did not have this built in our system, and we were going to need to do that build. We're also very lucky to have a wonderful informaticist that saw our vision, that was able to read these very easy to read publications. So I hope all of you go out there and read it. Sometimes they're written at such a high level that you're, trying to look things up to see what they mean. But it's written at such a level that you're thinking to yourself, this is clearly an attainable goal.
Thanks for the plug, Mary Jo.
Yeah, I think that all of us read it. And then anything maybe we didn't understand, because we had that interdisciplinary team, someone was able to translate it. Someone was able to say, this is within the realm of our system. We can do this. And I think when Katie and I first spoke and I heard that there was no hard stop, I can remember going to Jean and saying, they can't say no, right? And then rightfully so, those hard stops and those clicks, we look at all them, we figure out how many there are, and they're right. They were getting taken, carried away, and we needed a way to stop that. So I think that was probably, that interdisciplinary team was so important to the success of our build.
That's absolutely wonderful. And I think that's a great segue into now talking to you, Jean, and hearing about how it integrates into your daily work and your daily practice.
Yes. So this was a huge change, as both Dr. Drago and Mary Jo have discussed. Most people are not educated in geriatrics per se. And if you work in pediatrics, those doses. And depending on your work area, if you don't work with pediatrics every single day, you can see the panic on people's faces when they have to dose or medicate a pediatric patient. You have two people double checking, the reference books comes out, everybody's worried, but not one person looks at a 75, 80-year-old getting Ambien or Flexeril and says, oh my goodness, we have to make sure that this patient has the correct dose. So, Mary Jo was explaining they wouldn't let us have hard stops. So instead, we said, let's not even have them have a consideration. Let's put the right things in front of them so that if they're, don't have any idea, we are doing what the electronic medical record, what they think it does for them, giving them the suggestion and the alternatives that they're supposed to choose from. And it's been pointed out at multiple facilities, at Dr. Drago's facility, and all of our facilities at the network that Mary Jo and I work at, no one noticed. So, we didn't make anybody angry. We thought with our nice side panels, we were going to educate everybody. We were going to teach everybody what a Beer's drug was, and people were going to be walking around happy that I know what a Beer's drug is. And no, they ignored them. So we made no impact at all. So I'm very happy to say that we are seeing the results that Dr. Drago is seeing. For most of our medications, we are having, a 40% decrease in the dose that our patients are seeing. But more importantly than that, the new research we're looking at is how often are those meds being prescribed? And for a medication like cyclobenzaprine, which is Flexeril, which is a muscle relaxant, people were getting that every 6 hours, 3 times a day. We're now seeing that those prescribers are putting it as a once or a once PRN. So not only are they getting a lower dose, but it's not continuing on. And one of the biggest concerns is starting an inappropriate medication while somebody is acutely ill, and then having that medication go home with the person so that without the expert medical attention and care looking for adverse drug events, we have somebody going home on a dose or frequency that's inappropriate. And that's muscle relaxant, sleeping pills. We want to make sure that, they're safe in our facilities, but safe again when they go home.
It sounds like in so many ways, Jean, there is not just a shift in the decision-making, but the decision-making tree is coming up even closer to the process of where the providers are making their decisions. You don't have to make so many decisions later on down the road. You get to cut off the tidal wave before it continues and flows into a bigger problem down the road. And it really limits a lot of that risk, that risk that comes with having to transition that medication into the conversations with their primary care doctors and seeing what the long-term effects are there. And that also really makes such a big difference for the way our patients who are being seen at different sites and facilities receive care. So that is just absolutely amazing.
Yeah, so not only prescribers are not educated in geriatric prescribing, but nurses do not get that education and pharmacists don't get that education. So one of the first questions we talked about was how much of an impact were pharmacists making before? How often were they calling prescribers on inappropriate doses and asking for doses and frequency changes on our older adults? And I look through data to see, because our pharmacists in our network record every interaction they have with prescribers. So we can see what kind of phone calls they're making and why and where the potential issues are. And unless that patient had renal dose insufficiency and they were calling to change the dose for that particular problem, there were no phone calls made from the pharmacy teams to the providers to say, we think this dose or this frequency is too high. So could you please change this medication to make it at a more appropriate dose for that elderly patient? So that is a huge thing, because we want to make sure that the providers are making those decisions when they're putting in the order. We don't want them to get to the end of the order entry process and then have to go back and rewrite the order or answer a question or justify, because a lot of those providers just put appropriate. Mm-hmm. And then it goes to the pharmacist, and the pharmacist isn't sure of what the appropriate or inappropriateness was. And they said, oh, the physician put appropriate, and they passed that along. So we want to have that decision made as early as possible. And again, it goes back to our pediatric patients and making sure, that our older adults are being treated in the same way that our pediatric patients are.
Mm-hmm.
And I think it was Mary Jo who was talking about the American Geriatric Society, which does update the Beers criteria every 3 years. So our next step, and I think that Dr. Drago is also going to take on this step in the West Coast, is to look at the alternatives to these medications. And our network does do this with one medication drug class already with sleepers. Because we find that more than 50% of the patients who come in and are put on a sleeper in our facilities were not on a sleeper at home. So when they leave, those physicians continue to use those sleepers at home. So we do have a block on our electronic medical record, which we're very proud of, that if you are not on a sleeper at home, you cannot order a sleeper here. It directs you towards the better alternatives such as melatonin or trazodone. So I think that that's going to be our next steps, is to not only point people in the right directions as far as doses and frequencies, but also to give them the proper method and drugs to use instead. And I would be very remiss if I did not put in a statement that, of Caitlin O'Prandy, who is our geriatric pharmacist in one of our facilities, who was tremendously helpful and did a lot of the research to get these medications. So I want to thank Caitlin for her desire to help older adults, and she's a huge part of this team.
That's amazing. And it sounds like even though your sidebars didn't end up doing that education you were hoping to, the practice that you're doing now actually is doing a lot of the education and the empowerment of the staff as well, being able to give people the opportunity to voice and to say and to make those right choices as the GPC helps the process along. We have a couple of final questions that we'd love to engage you all on. I'll start off with you, Mary Jo, if that's all right. We'd love to hear from you. What surprised you during the whole process?
So I think probably the best way to answer that was the silence. Whenever I've implemented other things in the electronic medical record, there could be a flood of questions. People take out IT tickets. There are concerns from folks, right, after go live, or maybe just something isn't linked correctly. And we really expected a lot of providers to reach out with clarification or need for additional training, but none of that happened. And the rollout was remarkably smooth, so much so that people should feel very confident that this is something that they can easily try. And then I think one of the other things that really surprised me, and I hope Dr. Drago will comment on this before we end, but really was the onus of the nurse in this process. And our physicians, we can be very quick to say the physician ordered it. The pharmacist also, Jean shared a great story of when the pharmacist looked at the order and the physician said, this is what's necessary, right? And we all just have this innate trust in each other. But the voice of the nurse in care settings when they suggest medications is also very powerful to our providers. So I want to take just one moment to explain how important it is that no matter what level you're at, educating yourselves just by looking up, Googling the Beers list, right? Educating yourself on this very simple list of medications is a responsibility that each of us should take. And it's a responsibility that each of us should have when providing care.
Thank you for bringing that up, Mary Jo. We at OHSU last year, we actually did some focus groups with residents who in an academic institution, they are the front line. They are the ones writing the vast majority of the orders. And in these focus groups around safe prescribing, what are the facilitators? What are the barriers? One of the fascinating things that fell out of this conversation across focus group sessions was that by and large, the residents know when they're being asked to prescribe a medication that is risky, they have that training now, which I didn't have, and I bet you didn't have when we were in their shoes. They have it now, but they're finding themselves in awkward positions when it's a nurse asking, hey, here's what's going on. Can you order some hydroxyzine? Which was, for some reason, the drug du jour here in Oregon right now. I don't know why. But the residents know, ooh, this doesn't feel right. Yet the nurse is asking me, and they must know something I don't. And so much work for so long has focused on, in safe prescribing, has focused on prescribers and pharmacists. And I think only now are we starting to recognize that the nursing voice in these discussions around what to prescribe for X, Y, or Z condition carries a lot more weight, plays a bigger role, maybe than the research in safe prescribing has given it credit for up to now. So I assume the majority of the audience for the Nursing Insight podcast are nurses. And so I hope this is one of the few things that maybe listeners walk away with, that your words matter. And so educating yourself, building up your capacity to make good suggestions, and even just recognizing that when you're on the phone with a resident, with a new faculty, with, that poor surgical intern that's wearing the belt of pagers, that your suggestion can actually sort of kick off. Are we going to go down this path, or are we going to go down that path? And that can be pretty consequential, not to put a whole lot of pressure out there, but you play an important role. And so don't feel like your words don't have value. They really matter.
And I think what you're saying is absolutely true. As people are going through medical school, pharmacy school, nursing school, we're all being taught that, it's a triad, mm-hmm. It's multidisciplinary, it's interdisciplinary, and you should be talking to each other, and there's people who know what you don't know. Mm-hmm. So when we're offering those suggestions, we need to be sure that we know the answer, and it's not based on experience, but it's evidence-based medicine.
Right.
Absolutely. And Jean, could you tell us a little bit about how you think this model could scale across different systems and maybe different healthcare settings?
Yeah, absolutely. So this is a very easy model to introduce to different types of sites. Our network has teaching hospitals, it has community hospitals, and what's applicable in a teaching hospital is applicable in a small community hospital. It's an older adult is an older adult. We also give the providers the longitude to choose a different dose if it's appropriate for that patient. Mm-hmm. So the best thing about this practice is it doesn't lock you in. It's not a hard stop. So if you feel that this is different, a different dose is required for your patient, maybe they're a psychiatric patient with a long psych history and they do need a higher dose of quetiapine or Haldol, it does allow you to have that bandwidth to make that change that's specific for your patient. So I think this process is very easy to scale because it does fit in with any practice site. And, we're working right now on our ambulatory process for this. So we will get back to you when we get that launched and let you know how it's working out in our ambulatory settings.
We're looking forward to hearing back from you. And also for you, Dr. Drago, are you seeing further plans for more EMR implementation or optimization?
Yes. I think after all this wonderful discussion about what the GPC is, the sort of breadth and depth of what it can do, both for staff and for patients, I think it's also worth acknowledging that this is not the one-size-fits-all solution for all things medication safety among older adults. This really is a tailored, focused intervention addressing dose-related funkiness and adverse drug events that commonly befall older adults. But there are lots of other facets and lots of other little areas of safe prescribing that the GPC just doesn't touch on, right? It's not what it's built for. I think the best example and my kind of next step, assuming I get to choose those sorts of things, would be to focus on what I have come to call those never use medications, where the issue is not so much about the right dose or the right regimen for safety. The issue really is we just should not be prescribing this ever to an older adult unless it's a pretty rare circumstance. My favorite drug to hate on in this area is scopolamine patches for post-op nausea and vomiting. I have seen some crazy cases of delirium that have been directly related to that scope patch that got put on in the PACU, and could tell you some really fun stories, maybe for another podcast, about chaos that ensues on day 2 of the scope patch. And so the GPC, right, with that, it's really not a dose thing. It's a no, we should be using something else. But Jean alluded to this, and I think HMH has been kind of out front on this. Using the EHR, finding ways to leverage functionality in the EHR so that when that prescriber goes in to write that no scope patch for the patient coming out of the operating room, it directs them instead to saying, this patient's 85 years old and has Parkinson's. Why don't we recommend this instead, where it's just one click and you get over to ondansetron, ODT, or, another alternative, maybe, a little bit of Pepto or some PRN ginger ale. And so we make it as easy as possible to just single click over into something that's more appropriate. Again, not a hard stop. You're approaching providers or prescribers in that point in the process where they are still swayable to a safer alternative instead of letting them go all the way through ordering this scopolamine patch and then sending them back to square zero. And so I think that's HMH has proof of concept here for something like this. And there's, as I was told once by a physician informaticist, there's a lot more medications that could use that kind of treatment. Why don't you go ahead and take care of that?
That's absolutely wonderful to hear, because it really is going to make, just as you saw with the GPC, it's going to make such a difference as you go in and start really increasing the support rails, those bumper guards that you have around all the medications for all of the patients. It has been such an inspiration to talk with the three of you. You are really trailblazers in the way that we can harness the technology and the systems that exist to have better patient outcomes. So thank you three so much, Dr. Drago, Mary Jo, and Jean, for joining us today on the podcast. It has been a genuine joy and pleasure.
Thank you.
Thank you so much, Stephanie. This was great.
Thanks for listening, everyone. We'll see you next time on the Nursing Insights podcast.